Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between. Hello, we are back again with none other than Dr. Peter Leo, who needs no introduction to the dermatology crowd, but he is a clinical assistant professor of dermatology and pediatrics at Northwestern University. He received his medical degree from Harvard Medical School and his dermatology training at Harvard. And while at Harvard, he received formal training in acupuncture. Dr. Leo is the founding director of the Chicago Integrative Eczema Center and founding faculty member of the Integrative Dermatology Certificate Program with over 400 publications and 5 textbooks. Dr. Leo, thank you so much for joining us.
My gosh, it's my pleasure. Thanks for having me.
It's great to have you. And I have to say, the 400 publications are your publications are among my favorites. Anytime you post one or I see one come out from your group, I always have to read it because they are fantastic. I have probably a million questions, but maybe we can focus even on your most recent ones. I'd love to ask you about, I have a list here. The top ones actually sounds like there's some news that's come out with the topical steroid withdrawal world. So I feel like we have to talk about that first. And then originally I had really wanted to have you on to discuss some of the work you've done around atopic dermatitis and the metabolic possible connections there, GLPs, because that is so interesting. We hear a little bit more coming around psoriasis, hidradenitis. We're not hearing much about atopic derm. So would love to talk about that. Plus, then you have another paper that I saw about botanicals over the years. Also interesting. Should we start with topical steroid withdrawal? Because it sounds like there's some breaking news there.
Yes, it's always fun to break news live on a show. So this just in, the CDC, Center for Disease Control, has just approved an ICD-10 code for topical steroid withdrawal. This is a big deal because up until this point, we really haven't had a formal diagnosis code, which means it's really tough to study it because people aren't recording it the same way. And it also kind of undermines it being a real thing. People say, well, there's no code for it. Like, it's not an acceptable thing. It's not a real diagnosis. But now we can actually study it. And we can actually say, actually, yes, there really is a thing. There's actually a diagnosis code. Now, that doesn't mean we understand everything about it by any stretch. We have a lot of work to do. But I think this really is the first step to getting better and more refined information about it. And I'm really excited. We've been fighting for a while.
That's so exciting. We love to be breaking news platform as well. So that's wonderful. And do you have any thoughts on, because it's still pretty hard to diagnose, I find. And it's not really part of our current training to really get diagnostic criteria, maybe because they really haven't existed in a really formal format. But do you have any thoughts or just lessons to the rest of us? Like, what do you use in clinic? What do you see in patients where you start to say, wait a minute, is this more just their topical steroid withdrawal? If you have any pearls there.
For sure. And we're really excited. We just had this paper come out in the British Journal of Dermatology where we were able to use kind of a multiple rounds of the Delphi method to come to some conclusions about some really helpful diagnostic criteria. Now, it's not a formal diagnostic criteria with major and minor stuff or anything like that yet, but it really starts to list the criteria we can think about. The truth is, spoiler alert here, I think that for especially a skeptical group, I don't think I can convince you that it is substantially different from super severe refractory atopic dermatitis. So at some point, it starts to really overlap. Now, I think there are some signs that really help me decide one way or the other, but here's the upshot. At that point, for somebody with super severe atopic dermatitis or TSW or both, because it really does seem to be that there may be this overlap, it's sort of part of the same spectrum. Those patients who have used and abused tons of steroids already, my take home point is just that you can say, listen, maybe we don't know what TSW really is yet. We have some great ideas. And Dr. Ian Miles at the National Institutes of Health wrote a beautiful paper talking about how this might be a mitochondrial problem and this complex 1 chain in the mitochondria. Really exciting and interesting stuff. So there's something here. There really does seem to be something there. But I would totally agree we're not fully there yet. We don't have the full pathogenesis worked out. All that being said, though, when you have a patient where you're not sure whether it's super severe refractory eczema who's overused steroids or TSW, here's the beauty. You can treat it the same way. You want to help them get better. You want to soothe the skin, fix the barrier, help the dysbiosis, all the things we do. The only difference is we don't want to use more steroids for these patients. But to me, it's very easy. And what I often say is that part of the reason I think really good clinicians often say, I don't see this. I haven't seen this. Why is everyone keeps saying it's so common, but it doesn't happen? I think because good clinicians at some point say, okay, you're using too much steroids, like you're abusing them now. We have to do something different. And they'll move to all of the non-steroidal options, everything from phototherapy to the biologics to the JAK inhibitors, even to conventional immunosuppressants. And when you do that, you realize, again, that Venn diagram perfectly overlaps. That's essentially the treatment approach to both TSW and to super severe atopic dermatitis where we've overused steroids. So at the end of the day, I think we are in good shape and we don't necessarily have to prove the difference, but I'm hoping we're going to get more and more tools to get precision-based medicine to say, aha, this is the difference. And this really is the pathogenic twist, so we can understand not only how to define it and to diagnose it, but ideally how to prevent the darn thing in the first place.
No, that's so great to know. And I'm curious how has it changed your thoughts about what you start as first line for patients? I mean, there's the practical barriers because we do have a lot of non-steroidal options now as far as topicals. There are the practical implications of most things can't get covered and all of this, but assuming the world is our oyster, we can get everything covered, no problem. They can walk into the Walgreens and get exactly what we prescribed. Has it kind of changed? Did you go for non-steroids first line? Has it changed at all for you?
It really hasn't. I think there's sort of a narrative out there. Like the fun narrative would be like, this guy's a shill. He's just trying to sell out and he only wants you to use the super expensive non-steroidal medicines and he doesn't use steroids anymore. It's like, yeah, that would be a neat, tidy story, but it's not the truth, as an action. So no, I still use steroids as a first line and essentially almost all the time. The only time I'm not using steroids is when I really feel like they're using and abusing them too much, or in a case where a patient expresses concern about it. And I meet a lot of families who are nervous and I say, listen, you've used, again, they've used them. These are not people that are just a priori saying, I'm never going to touch steroids. These are people who come in with 5 empty tubs of triamcinolone. And I'm thinking, okay, you've used a lot. Why don't we try some other things? And again, this doesn't mean it has to be a super expensive new medicine. Tacrolimus and pimecrolimus are now generic. Phototherapy's been around for a long time. These are other things we can do. And those who really know me know I also do a lot of integrative and alternative medicine. So it might be using some other natural treatments or acupuncture or Chinese herbs. So there's a whole bunch of things we can do outside of the super expensive things that people I think are afraid of trying to take advantage of this. So I don't think you have to do that, but there is a middle path where you can say, I think you can use your steroids safely, but if they're not safe, then we're going to move on.
Oh, that's great advice. Actually, maybe that's a good then transition into the botanicals and the other kind of work you do. I'd love to hear about the paper you guys wrote recently as well, if you want to give a few highlights from it or a little overview.
Yes, a wonderful student came up with this idea. And the idea was that across different cultures, places where we're pretty convinced they were very far apart, they probably didn't have much direct communication thousands of years ago, you will see the same botanicals getting sort of discovered independently and used in a similar way. And we thought, what a cool concept, right? These are sort of things that really have replicated themselves over and over and over. So in a way, it's almost like a flag. It's like multiple cultures have found this over time. This is probably something worth looking at. And we dove into that a little bit in the paper, and it was really fun. It's more of a narrative review. It's not anything a breakthrough, but it was just fun to look at that and think about how some of the botanicals that we really can enjoy have been found by multiple cultures over time. And some of the things I think about are coconut oil, and coconut oil is just an amazing botanical. It has some antimicrobial effects. It's kind of soothing. It is pretty moisturizing. It can do a number of different things. And when we look at these different botanicals, we wonder, how can we leverage them? How can we learn more about them and incorporate them more? And of course, many of our modern drugs really do derive from plants. It's not even that exciting for people who have a sense of the history of medicine. Almost everything we do started with somebody brewing a plant or biting on bark or making a tea of something, right? That's where it always begins.
Oh, true. And that's so, I love those, the history, the pharmacology. And for others who also love it, we'll put the link down below to the articles we discussed. They could look it up. And now to the main reason I wanted to have you on, but it's since the time that I chatted with you about scheduling to talk about this next study to now all these other amazing things came out, which we had to touch upon. But so originally I saw this article that you had put out with one of your mentees about the gut-skin axis, atopic dermatitis, and that connection to metabolic disorders, possible GLPs. And I guess we discussed, we're still very early, I think, in dermatology, even for psoriasis or hidradenitis, but we're seeing a lot more develop there. Atopic dermatitis, we haven't seen a whole lot come out yet. So I would love to kind of do a bit more of an in-depth discussion of where you think that world exists. And you guys mentioned the short chain fatty acids. There might be a connection there. So we'd love to delve in further into that.
Thank you. Yeah, it's been so fun. When I actually, when I was in medical school, I was interested in this neuroimmune cutaneous endocrine, or NICE network. I was already fascinated. One of my mentors was actually an endocrinologist who was studying stress responses. And it was just so neat to see, like, wow, there are these little loops that can seem to kind of reinforce each other, and stress can affect different aspects of the skin and inflammatory system. So we know this is a thing. And then in the last couple of years, they've kind of fleshed out this other concept, the SING, skin immune neuro gastroendocrine. Now, before you laugh, because it is getting a little ridiculous, you realize we are zooming out and we're getting a more holistic view. But this is how we build a holistic view, right? You start with something kind of very, very refined and focused, and we strip it down to understand the basics, but then you start to put the components together, right? It's like building a circuit. You start simple and you build. And I think we're starting to see that there really are holistic webs that connect everything. And a really functional, practical way is to look at this gut-skin connection in terms of obesity and some of the anti-obesity drugs, and also how these are all affecting inflammation, the microbiome, both on the skin and in the gut, and ultimately affecting the disease. So, I think we've known for a long time, as you said, psoriasis and obesity very deeply connected. And I think you can show it both ways. There's an increase in obesity with that correlates with severity of psoriasis, and real practical. If patients lose some weight, they often do better with psoriasis. So it really does seem to be causally connected. For atopic dermatitis, maybe not as much is known on this. I will say Jonathan Silverberg years ago published a paper where he found this connection with severity and obesity with atopic dermatitis. And I remember being a little shocked, like, I really didn't feel like it was as strong, but maybe there is something to it. And sometimes you need some epidemiology and numbers to see something that might be harder to see just day-to-day in clinic. But now I think we're understanding that obesity really does affect the inflammation, but it also affects our gut microbiome, which again affects inflammation, barrier, and sort of the homeostasis of the whole being.
That's so great. It's amazing just to kind of start to look at that connection more and more. And then, so what would you recommend for, like, do we have enough there for us to start as, like, today as dermatologists incorporating things? And within that, I mean, should we be starting to look at people's home IRs, let's say, for atopic dermatitis, and check their insulin and glucose? And what's like a practical approach right now? Do you think that we should we or shouldn't we? And if we do, what practical things should we add on for atopic derm patients?
I think we're getting there. I do think that if someone is overweight, and if we feel like their diet is not so good and their health is not so good, I don't think anybody needs any convincing to realize that's going to make potentially everything worse. If we can get them so that they're fit and trim, and that their metabolic system is functioning better, we kind of have a sense they're going to do better overall. But I don't think we're quite at the level yet where measuring those things is going to really help us, because part of the problem is that we know, like, the GLP-1s and their cousins, the dual and the triple agonists, these things they're kind of working in a number of ways. Not only are they having an effect on the obesity over time, for sure, which has some direct effects when we decrease our the adipocyte number, we change the inflammatory milieu of the body and change sort of the balance. But as a chemical, they're also having some direct effects as well. And then third effects on the gut microbiome. And this is something interesting. There's sort of this little, like, yin yang in the gut, where certain bacteria are going to produce these fatty acids that are really important, and I think can be anti-inflammatory and can help balance things out. And then other things can produce more toxins and things like lipopolysaccharide that are going to cause inflammation. So we have this, like, delicate balance. And if we change the environment too much too quickly, we can really get into trouble. So I'm a little nervous to just tell everybody, just go on one of these things and you'll do better. But I do think that the general concept of being more fit, being more trim, and eating healthier, it's great. It's hard to argue with that in general.
That's true, right? I mean, you can't go wrong with maybe better nutrition, checking body compositions, maybe just getting more fitness in. But then when we start intervening with GLPs, I think that's the world we're trying to figure out. And it seems so far, I have some patients on GLPs too. It seems like things generally, even though we might not understand everything, things generally tend to go for the better. So I do think that this is a world we should be really looking into as dermatologists. And I know there's always some debate on should we even be prescribing the GLPs? For me, it ended up being just a practical thing of, if we're not able to get our patients into endocrinology, then, because the step was always, sure, I'm going to refer you out, and that's, it's a new workflow I have to learn, so I'm not going to do that. But then eventually, as patients were waiting a long time, I was like, I could just prescribe this, because we prescribe harder medications, right? We used to prescribe methotrexate and things like that. So it can be done. So I'm curious what your thoughts are of kind of the dermatologist's role in this. And it might not be fully defined now, but do you think the GLPs, the GIPs, all the incretins are going to kind of become a mainstay for us, eventually prescribing and managing?
It sure does seem like it. I mean, as I meet more and more patients, my practice is kind of transformed. And you can kind of tell when they come in, people that clearly were heavier, now they have that kind of gaunt look, but they also look healthier. And I think they're more active. You get this virtuous cycle too. When you lose some weight, especially people that have been struggling for a long time, I think then they get this virtuous cycle of improvement. They look better, they feel better, they sleep better, they're doing more exercise. Like, so I think it really can be a good thing. Now, are there potential dangers? There are. There are some risks to these things. There are long-term risks that I don't think we know yet either. And I know I've had some patients say, well, when's the other shoe going to drop? And in 10 years, are we going to hear about some terrible catastrophic side effect? And it's like, maybe we really don't know, but we continue to learn. And again, for the appropriate patient, somebody who already, we know they have increased risk of heart disease, or if they're battling diabetes, kind of the original intent of these medicines, for those patients is a much easier trade-off. So we're learning from them. And I think as we get more comfortable, as you say, it may be one of those things in the future where it's almost standard. You know, we think about statins. It feels like pretty much every one of my patients is on a statin and on a high blood pressure medicine too. It's like if we can keep it a little lower, it really does seem to be connected to better health overall. So maybe it will happen there too, for sure.
Yep, absolutely. And I agree with the patients that come in and they might have clinical obesity, makes it easier. The non-obese patient, I think, is touched on this in the paper as well. That's a bit of a tough one. And like the skinny fat, right? Like patients that don't necessarily meet the BMI definition of obesity, but may still have a body composition that isn't quite healthy, higher fat content, and still have maybe a irregular insulin to glucose ratios and have that metabolic dysfunction. I've been checking more and more insulin and glucose, but then there's a subgroup where you're like, well, now what do we do? Because they don't fit diabetes, they don't fit, for the weight loss categories, which actually in California, even for weight loss coverage is becoming even harder for the GLPs. And of course, there's the original nutrition weight, but we know how hard that is too in real life to actually implement those things. I'm curious what you do for that subgroup. Are you checking metabolic factors in the non-obese patient, or just really kind of having the BMI be a trigger of that workup?
It's such a compelling thing because we know that, like, for example, the GLP-1s, they upregulate some of the key pieces to make the gut less leaky, like these tight junction proteins. They also we can show they decrease the translocation of LPS. So we know that they're decreasing toxin mediation and stuff. So you could also make an argument, even if you're not really obese, should we be doing these for these other reasons? Because there really are some reasons. But I'm not looking so far. I think a lot of my patients are pretty severe with atopic dermatitis, and usually I'm kind of focused more on targeted treatments for that part first, mostly the biologics, JAK inhibitors, things like that. And then the good news I found is that in general, if I can get their skin under control and get their sleep better, I often am kind of working on the other side of that vicious cycle, get all that better. And then I find the patients often feel better, look better, and they get healthier that way too. So I think you can kind of approach it like any vicious cycle. You can start in a number of places. And there's no doubt that for some of these patients, the gut leakiness or that imbalance or these metabolic abnormalities are driving it. So you could approach it that way. And I think to some degree that's going to be helpful. And we know, for example, in hidradenitis, I think this is another place where it could be really important to at least target that. But as a dermatologist, at least in 2026, I'm a little more comfortable starting with the things that are a little more directly affecting the skin. And then if they still weren't better or wanted to seek out more, then I absolutely offer that. The other piece of this story, and it's weird because I've written this paper all about this, so you'd think I'm a big adopter, but I really haven't. But I still love the ideas and I'm interested in those ideas. But the other way that I'll approach this is I work a lot with nutritionists and dietitians. So I'll encourage my patients to see somebody formally. I know a little bit about it, but I don't feel qualified to opine so much. But I love to say, listen, if you have a lot of questions about food, and most of our patients with AD really do, I like them to talk to somebody a little bit more in detail and get a more, more advanced plan. And I think that's really powerful. And that's a little bit more of a natural way to do some of the things we're talking about, weight loss and metabolic health, without necessarily needing a drug, knowing that there's pluses and minuses to both.
That's great. Sounds like you have really good nutritionists in your group too, because sometimes that's the barrier, finding a good nutritionist to send to, who will sit down and do the right things. Because I have sent people out before and they come back and say, they basically just like a handout, eat vegetables type of thing. So sounds like you guys have a very great multidisciplinary group that you work with.
It is a network, not necessarily my group, but I have some folks that I can refer to. And one of the things I'm lucky, I found people that will do a lot of work. So the main person I send to, she's actually based in Philadelphia area. So Jennifer Fugo has a kind of an online presence, a lot of education. It's great. I can send patients to see her virtually, and they get a lot
That's
of
great.
support. It's fantastic.
That's a great resource. Can she see people from different states and all those?
Yes, I
Okay, we
believe
found another
nationwide.
great resource here,
Yes.
because it is actually, that's a piece that's hard to find. And our patients ask. It's not that they don't want this knowledge; they want that referral. But a lot of times, you don't. It's hard to find people that really kind of understand their skin disease and how everything kind of relates. So that's, again, a fantastic resource. So thank you so much for covering everything. And then this is, of course, the Future of Dermatology podcast. So at the end, we always ask what you're excited about for the future. It could be pertaining to what we talked about or anything at all in dermatology. Do you see anything coming up in the next 6 to 12 months or beyond that you're excited about?
So much exciting stuff. I think the world of atopic dermatitis, we've gotten to go. I'm old enough now that I got to start when we had literally nothing, no FDA approved treatments. And now to the point where we have this huge treatment landscape. But the best part is we're in the midst of what I call the virtuous cycle of drug development. We get new treatments, but that also teaches us more about the disease, which in turn
Right.
leads to better treatments and better. So the pipeline for atopic derm and itch is just unbelievable. And I know it's true because I'm so busy all of a sudden. Like, I went from zero to hero. Nobody really cared that much about eczema. And now it's just amazing. And there's so many new things to digest that I feel lucky that I get to talk about it, think about it, write about it. And I feel like I kind of was in the right place at the right time as this has really taken off.
Well, that's amazing. It's true. The eczema world is really just exploding. We're learning so much more, and even the nuanced things like the topic steroid withdrawal, the metabolism. We started with this broad, not knowing a whole lot and having limited therapies, to now just being able to go to such complex places with it, which is really exciting. And it's in part to your work and our colleagues who spend a lot of time, thinking about our patients. So thank you so much for all of the work you do, and thanks for joining us today.
Thank you so much for having me, and I hope to see you soon.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.